green arrow.
It's funny, I pre-recorded this talk because I didn't think I was going to be here. And to actually give it now is quite weird. Like, I was hoping I'd come in just at the end to answer questions. Anyway, what I'm going to talk about today is an overview of the evidence for substance use interventions that we at NDARC, a few of us at NDARC, did in collaboration with some people at the European Monitoring Centre on Drugs and Drug Addiction. So do I keep pressing the green button? Thank you. So the problem, I've got a thing here about policymakers. What actually happened was the EMCDDA came to us and said, we've got about 3 months and only about 20 grand, and we need evidence for everything that works for substance use disorders. And I'm not sure why Michael contacted me about this. I don't know if he's in the room. Anyways, so, I mean, this is a common problem with policymakers, is that they want to just have a broad idea of what works and what doesn't work. Whereas us researchers, we like to do everything in detail, and our reviews are very difficult and time consuming. So the challenge was to come up with a way that we could get the guts of what worked without spending years doing it. So what we did was a pretty rough overview of reviews, or an umbrella review, because that's much faster. Mine just took a couple of months, but anyway. But it's kind of like the forest approach. It gives you a broad idea of what's happening without worrying too much about the details. So to do this, we searched PubMed. And PubMed, I'm sure you all know, is freely available. So anyone out there can do this, even if you're not a researcher. We use medical subject headings, or MESH headings, and we picked up the terms in the MESH dictionary that corresponded with cannabis, stimulant, and opioid use disorders, and we limited it to those disorders for our sanity. And then in PubMed, there's a flag that you can click that identifies just those studies that are systematic reviews or meta-analysis. Isn't that convenient? Because that eliminated about 10,000 papers. And we also just constrained the time frame. It's a little dated. We did it up until 2021. Then we went through and we hand searched, and we had to drop a lot of things that just weren't relevant. But we then took any systematic reviews or meta-analyses of interventions for these 3 different disorders that were based on randomized controlled trials. And that was just a way of managing the task, but it's also the most robust evidence. And then what we did, a lot of these were Cochrane reviews. And we took the evidence statements, which you find in the abstract of the Cochrane review, or if they weren't there, we had to go and search for them. And an evidence statement is like, there was moderate quality evidence that CBT did X. There was low quality evidence that bupropion did Y. Where we then graded them using the Cochrane system. And usually, like I said, that was already done for us. But sometimes we had to do it ourselves. Then we came up with what we thought was a kind of a pretty way of presenting it to the EMCDDA that was pretty more accessible, I guess. No, I don't want to do that. There, I'm not going to be able to point, I'm sorry. But you can see on the left, you've got the quality of the evidence, and it ranges from high quality through to very low quality or insufficient evidence. And across the top, we have whether the intervention was beneficial, did what we wanted it to do, there was no clear benefit or a potential harm. It was funny because I was so proud of this system of visually displaying this, and they came back at the end of the project and they said, it doesn't meet our visual requirements for people with like color blindness. So it's gone. Anyways, but I think the point to note here is that moderate to high quality evidence is kind of concordant with the Cochrane rating system. You can believe that the intervention will do what you think it's going to do. Whereas if you've got low quality evidence, you've got to be a bit more cautious because the intervention might change. The evidence might change with more evidence. Sorry, that's a bit tautological. The outcomes of the intervention might change with more evidence. And if you've got very low quality, don't even go there. So we pulled all of these evidence statements together, and rather than just put them on the EMCDDA portal where no one will ever see them again, we've put a lot of them on the NDARC website. And you can see this URL here. It's under resources on the NDARC website. And you can go there and you can just browse all of the evidence statements we found. I don't have time to go through all of them. So I just want to go through the psychosocial, the stimulant use disorder interventions. Now, reassuringly, psychosocial interventions are effective relative to doing nothing at all. So it's better than doing nothing. But within the psychosocial interventions, the only standout that improved outcomes relative to treatment as usual was contingency management. It both increased abstinence from stimulant use and also increased retention. There was low quality evidence, again, a bit nervous about this one. 12-step programs may increase abstinence more than treatment as usual. And interestingly, low quality evidence that CBT may not be superior to treatment as usual. And as one of our forerunner interventions for stimulant use disorders, this is actually quite interesting. So low quality evidence, can't be sure, but increasingly evidence is pushing away from that being better than treatment as usual. In terms of pharmacotherapy interventions, there's actually there's good evidence that they do not improve retention in treatment. I'm sorry, the color of the stars here is incorrect and I didn't notice that. So it's interesting because you'd expect that giving psychostimulants to people in treatment would improve retention, but there's actually pretty good evidence that it doesn't. We know that antidepressant medication doesn't reduce cocaine use. That doesn't mean it doesn't work as an antidepressant. Now, what's interesting is that we've got low quality evidence that prescription stimulants may be associated with a small reduction in cocaine use, but it's low quality evidence. And we've similarly got low quality evidence that prescription stimulants may not reduce methamphetamine use. Now, there's a review that came out in Addiction last week, you might have seen it, and it kind of corroborates that. They're looking for an effect. I think it was a 7% reduction in stimulant use, and the p-value was 0.07. So not significant, but it's still low quality evidence, small scales. There's no clear evidence for any of the other interventions. So the good thing about this is it's comparatively easy. It gives you a broad indication of what works and what doesn't work. But the major limitation is it doesn't include all the available evidence. So for example, the really good study that Liam talked about isn't in there because there's no systematic reviews, there's only one study on it. It's also a bit frustrating because you can only include things where there are systematic reviews, and because of the evolution of research, there's really critical gaps there. So when you want to look at the effectiveness of buprenorphine, you can't do that relative to no treatment, because at the time buprenorphine came about, methadone was the comparator. So you can only say that buprenorphine and methadone are equivalent. So it's interesting in that way. We've only looked at RCTs, but it was actually very convenient to do that. And I have to say, it still took quite a lot of effort. So I wanted to share it with you because I don't want to waste our effort. So please have a look at our website and you might just find some evidence statement on there that suits your purpose. Thank you.
Sorry, before you go, are there any questions? Paul. Sorry. Oh.
Thank you. I was wondering, did you find any evidence about how peer support might be valuable in treatment?
We did, and from memory, it got the question mark. But why don't you go onto the website? Actually, no, better thing, have a look at the technical report that's on the website. And if you can't find it in there, contact me, because we did do some stuff on peer interventions. It wasn't the aim of this, but we did come across some evidence statements about it. Yeah.
G'day, thanks for that. Just on your question, I suspect there's not a wealth of literature around peer support, so there's probably not too many massive reviews of it.
Yeah.
And I just had a question about the results around agonist therapy, like psychostimulant prescription. Nadine told us earlier that most of the published studies to date are underdosed and don't have a long enough. So I'm wondering what the value is of meta studies that are looking at studies that may not show any effect at all because they're underdosed, because the sample size is so small, and because the duration of the study period is so short.
Yeah.
Yeah.
So I hope that you'll come to my talk on Tuesday, where I'll present more detail on that recent review. Most of the studies are for amphetamine, methamphetamine, use methylphenidate. There was only one that used dexamphetamine. Doses are fairly moderate. Actually, a lot of them taper up to about 180 milligrams. And I think that is a question, yeah, whether they're adequate, but I'm not going to make that judgment because I think there's only been, well, we might hear more from the Dean later in the week about high dose lisdexamfetamine and what that does. But yeah, there's not too many studies that do high dose. Yeah, thanks.
Thanks, Rebecca. Just to echo what you're saying about CBT, I was involved in a network meta-analysis. I'm not sure whether that met the criteria for your review.
It did.
Of the psychosocial interventions, which found that the combination of contingency management and CRA was the most effective,
Yep.
and was twice as effective as CBT.
Yes, and we definitely did read that review. And I think if you look at the detailed evidence statement, it kind of captures that CM plus CRA, CM plus CBT. Yeah, thank you. That's it.
Thank you. Yeah.
Thank you.